Thank you for the invitation to speak and share with you. I sort of chose this particular topic partly for convenience because I was asked to write a review for the brain. So since I've done quite a bit of work, I'll share with you today's talk. Of course, this is the content of what I want to share with you. Some updates. Of course, dengue is important in our region. So, and CNS dengue is a real thing. So I thought we could look at this topic. Dengue affect up to 400 million cases a year, and then 80% are asymptomatic, which I think is important. I'll raise this later on. And CNS dengue is said to happen in about 5% of dengue cases, and mortality is 1% for those who are hospitalized. So it's really an important topic, and the CNS dengue occurs particularly in serotype 2 and 3, and in those with the more serious dengue disease. So we submitted the review, and then this is a summary. Direct infection, probable is acute encephalitis, definite is chronic progressive panencephalitis, and then indirect complication, a number of them, and uncertain mechanism. These are, I will go through them and then share with you. So about acute encephalitis, you see the literature, they don't use the word operational clinical diagnosis of acute dengue encephalitis. They just say that acute encephalitis, and on the basis, some of the work were done actually in my hospital. This is 30 years ago, where you have a dengue virus isolated from CSF, PCR, and IgM. So with these sort of a basis, so you have a well accepted and well published diagnostic criteria, and basically it's based on the encephalopathy and laboratory evidence of a dengue infection. So this is well-known criteria, source, and published in Lancet Neurology and so on. So the first point we want to make is that because in many areas that are endemic to dengue, there is also JE is also very common. So there is a cross reactivity between the two viruses. So it is obvious that one has to check for both viruses to see what is actually the virus that's actually causing the encephalitis. So the recommendation is that you should check whether it's in the CSF or in the blood, both the IgM, and then see which one is higher, and then attribute the encephalitis to the one that is where the titer is higher. So, so the point is that when my colleague, Dr. Fong, he screened actually 230 publications. And at the end, you know, only 42 cases were acceptable, including they checking both criteria. So the point is that actually a lot of literature reported for dengue encephalitis do not really fulfill a strict criteria. So the next question I want to go into is whether dengue is really neurotropic or not. Just now, Dr. Hadi talked about neurotropic for COVID. Now, coming back to dengue, we already accepted a clinical criteria for acute encephalitis. Now, I'm throwing the question of whether dengue is actually neurotropic. The evidence for it is odd that you actually have 100 million cases of dengue yearly and 1 to 5 million CNS dengue disease, and yet there are so few autopsy reports of dengue brain. And this is one of them, which is well quoted. And then they found some dengue viral antigen demonstrated in the brain. And then and another one from Brazil, where there are 5 patients and demonstrated some antigen again, and non-specific changes. My point is that this is a chapter on pathological changes of CNS infection that was published a couple of years ago. And the conclusion of neuropathologists is that the evidence of neuroinvasion by dengue virus awaits further resolution. So the view of the clinician and the view of the neuropathologist doesn't really converge. That's a point I want to make. And in contrast to SARS, you see, the SARS is quite not SARS. I mean the COVID. The finding viral antigen in the CSF is quite common. And in fact, in the neuropathology, one can actually find PCR, but they are in a low titer. And just now Dr. Hadi talked about the area of pathology and the area where one finds the antigen doesn't quite correlate, So the conclusion up to now is that it is not a direct result of neuroinvasion by the virus in the COVID-19, but is due to systemic inflammation. Okay, I want to make the point when we wrote and submitted the review article, and we believe that direct neuroinvasion awaits further resolution in acute dengue encephalitis. I think we should be more stringent in the region on the clinical operational diagnosis of dengue encephalitis, and we should put more effort to collecting postmortem, to have more pathological study to see exactly what is happening in the brain. So the next thing I want to go into is a chronic progressive encephalitis. And this is actually only based on one case, but very well written up case which was published in 2019 by the group, ASNA group in Pennsylvania, NIH, I think is the case is from, describing a 45-year-old man who had 5-year history of progressive dementia or dementia, chronic diseases that involve extrapyramidal system and so on. And the interesting thing is that in the brain biopsy and subsequently in the postmortem, it was found that the dengue antigen is seen in the neuron, in the vessel, in the glass cells throughout in the hippocampus, basal ganglia, and cerebellum. So in the immunohistochemistry and so on, I think that it is a good evidence that actually the dengue virus actually is the causative factor. I just show you from the article, perivascular infiltrate microglia nodules, where the immuno staining is found, astrocytosis, and then in the CD8 cells, but not in CD20 cells, showing that it is a T cell response, and then this is where the hippocampus, the blood vessel, glial cells, all these places they found the dengue antigen. So this case illustrates that dengue can be a cause of chronic degenerative disease. And maybe we should open our possibilities or to these clinical possibilities. The third thing is to talk about encephalopathy, because the clinical diagnosis of encephalopathy is common, and it is due to various metabolic effect, as well as DIVC and hemorrhage and secondary to hepatic or renal failure. So perhaps it is due to there are literature that show that perhaps it's also due to cytokine storm resulting in increased vascular permeability. So it's due to the subsequent infection due to a different serotypes that make this particularly prone. Okay, so this is about dengue encephalitis. The post-infectious syndrome is more better described, although the pathophysiology is not so clear in some of them. And GBS, I think we reported this long time ago, and my colleagues had demonstrated that 20% of our Guillain-Barré syndrome has a positive IgM versus versus other neurological diseases, demonstrating the association of dengue with GBS. And interestingly, those who are positive for dengue, they have somewhat different manifestation. They are more likely to have diarrhea, more likely to have facial palsy, and more severe disease, requiring ventilation and so on. And interestingly, they are more likely to have demyelinating pathology rather than axonal pathology in the neurophysiology. And the IgG, anti-ganglioside IgG, is less, which is well known to be associated with axonal form of the disease. So the dengue dengue that triggered the GPS has somewhat different manifestation as those due to other causes. My colleague also, this is another post dengue syndrome, osteoclonus, myoclonus, ataxia, and then a number of other things in this ADM, cranial neuropathy, mononeuritis multiplex, that we are, I think a lot of us are familiar with. Transverse myelitis is another one. And long ago, we also reported this. And cerebralitis is not so clear-cut what is an exact pathophysiology. And then a myositis. But it appeared the myositis in dengue, they have good prognosis, and they probably related to cytokine-mediated inflammatory reactions. Because in a muscle biopsy, one cannot demonstrate the viral particles. So, so this is the last point I want to make to stimulate our perspective of dengue is to look at dengue may be associated with the CNS disease without evidence of systemic dengue. So, so that becomes important because dengue is so common. So dengue can cause CNS disease when based on clinical semiology, we don't suspect it. Okay, that's a point I want to make. The evidence comes from two studies. One is based in the dengue paper, very good dengue paper, work done in Ho Chi Minh City by the Oxford group, showing that in people with acute viral CNS infection, 4.2% has evidence, has IgM positive or PCR and so on, versus 1.4% of hospital control. And in 57% of these patients, there's no characteristic feature of dengue. Okay, so the second one is based on our own data. When we look at just now I share with you our GBS, where the IgM positive in 20% of the cases, which I share with you just now. But these patients do not have evidence, do not have symptoms other than vague fever of dengue infection. Dengue infection, the usual dengue infection, although they have some non-specific features such as cough, headache, diarrhea, and so on, but do not have characteristic dengue symptoms. So the point is that 80% of the dengue infection is asymptomatic, and this asymptomatic infection can result in CNS manifestation. That's the point I want to propose, okay, with the evidence I told you just now. I want to use analogy of Nipah virus. That's a conclusion in our review paper, that even asymptomatic for dengue or mild dengue can produce dengue-associated neurological diseases. I want to use our experience in Nipah virus. In Nipah virus, when we saw it encephalitis, there is a telltale feature of Nipah encephalitis, which is this small multiple disseminated hyperintense lesion in the brain. It's a telltale sign of Nipah encephalitis from dengue, from Nipah encephalitis. And we look at patients who are asymptomatic of Nipah and found that 16% of these people actually have encephalitis based on the MRI. And interestingly, you know, about 10% of Nipah patients develop relapse months later or years later. And these relapse patients, we call them late onset encephalitis when they were asymptomatic in the acute infection. So, an asymptomatic acute infection a few years later develop encephalitis that we call them late onset Nipah encephalitis. So most of them are due to relapse encephalitis. They have encephalitis, they recover, and then a few months or a few years later, they develop a relapse encephalitis. But some with exactly the same MRI feature and pathology, they develop late encephalitis sometime later, but without any evidence of acute encephalitis disease. So we use this analogical situation and try to propose that one should be open to dengue, CNS dengue, when a patient do not have dengue systemic symptom. It's very easy to check. You just check the serum IgM for dengue and see whether your patient has perhaps maybe due to dengue. Okay. So that's all I want to share with you today. And cảm ơn.